Good morning, and welcome to Grand Rounds. I was going to make our CME color. Morning. We were going to make the CME color silver in honor of our Buckeye friends who not only got knocked out of the final playoff, but also lost in the Big Ten Challenge last night. But having seen the beautiful pink suit that Landon's wearing today, the CME color is pink. So welcome to Grand Rounds. We got two great talks today. We're going to start off with a talk on TMR that Julie Mastracci is going to do. So without further ado, Julie.
All right, I am Julia Mastracci. I'm one of the PGY3s, and I'm going to be discussing the role of regenerative peripheral nerve interface and targeted muscle reinnervation in amputations. I have no disclosures. This is a brief outline, starting with some case examples. ST is a 63-year-old female who had dry gangrene of all four of her extremities after she required vasopressors for streptococcal bacteremia. She underwent bilateral BKAs as well as bilateral transradial amputations. Case number 2, LK, is a 55-year-old male with right foot synovial sarcoma. This mass was noted to be increasing in size despite multiple rounds of neoadjuvant chemotherapy. So he also underwent a BKA. And SG, a 43-year-old male who was in a bush hog farming accident and sustained a grade 3 open tibia fracture and a mangled foot, and he also underwent a BKA. These cases that I have been involved in led me to ask which of these patients may benefit from regenerative peripheral nerve interface and targeted muscle reinnervation in the setting of their amputations. Starting with some background, approximately 1 to 2 million people in the United States are living with a limb amputation, with approximately 185,000 amputations performed annually in the United States. The rates of neuroma range from 6 to 25% in the upper extremity and 4 to 49% in lower extremities. The rate of phantom limb pain ranges from 50 to 80%. And neuromas as well as phantom limb pain are painful, can limit prosthetic training and prosthetic use, and result in a lower quality of life. See if I can get this video to work. Maybe not, I don't have a pointer. Oh. Regenerative peripheral nerve interface, or RPNI, is a technique where a free nerve is implanted into a denervated free muscle graft. It is sought to provide the cut nerve a target when the axons are forming new neuromuscular junctions. A free muscle graft is created from expendable musculature, and it is recommended that this graft be 3 by 1.5 by 1 centimeter in size. The RPNI is created with 6-0 nylon sutures, starting with epineurial securing sutures, where the epineurium of the nerve is secured to the muscle, and then followed with muscle wrapping sutures, where the muscle is wrapped around the nerve after the epineurial sutures are placed. In the video here, you can see the surgeons are at the portion of the RPNI where they are wrapping the muscle around the nerve.
Julia, why don't you play the video in slow motion?
This is an animal study that was published recently in 2022, where they examined rats that had underwent sciatic nerve transection. They had 30 rats that underwent RPNI of their transected sciatic nerve, 30 rats who underwent nerve to stump implantation, where the sciatic nerve was sewn into a fully innervated adductor magnus, and 30 rats in the control group where nothing was done to the nerve. You can see here macroscopically at 8 weeks, so the bottom right picture, the nerve in the control group was forming a bulbous type nerve that did resemble a neuroma. And then in regards to pathology, at the 8-week mark, the RPNI group nerves were normally sized and maintained a clear and regular morphology versus the control group, where the nerves were densely packed and chaotically distributed. In addition, the RPNI group has statistically less transversely oriented nerve fibers, whereas you would expect in a quote-unquote normal nerve to have longitudinally oriented nerve fibers. Targeted muscle reinnervation is the transfer of a nerve to a new muscle target. The technique is as follows, where the surgeon identifies the muscle segment innervated by a single motor nerve using a nerve stimulator. The surgeon then identifies and divides the main motor nerve as it enters the muscle at the motor entry point, leaving a small stump of the motor nerve. Then end-to-end suture repair is performed between the amputated mixed motor and sensory nerve, or the pure sensory nerve, into the remaining segment of the motor nerve. It is thought that TMR eliminates wasted neural input to muscles that is thought to contribute to the development of painful neuromas. And it also can act as a biologic amplifier of motor commands, allowing for improved use of a myoelectric prosthetic in the upper extremity. However, myoelectric prosthesis will not be a focus of today's talk. Moving on to the literature, starting with RPNI as prophylaxis, and just some terminology. Prophylaxis here means RPNI or TMR performed in the acute setting at the time of amputation, whereas treatment refers to RPNI or TMR performed not at the time of the initial amputation. The study was published in 2018 and was a retrospective review where the authors compared 58 patients who underwent prophylactic RPNI at the time of amputation versus 52 controls who had amputation alone. The control group was matched to the RPNI group based on amputation site. The management of the nerves in the control group included traction neurectomy, suture ligation, and/or burial of the nerve within surrounding musculature. The indications for these patients' amputations was the majority trauma, with the second most common indication being infection. As far as their amputation sites, the majority of their patients underwent a below-knee amputation, with the second most common amputation being an above-knee amputation. And the most common quote-unquote recipe used in their below-knee amputations was RPNI of the tibial nerve, the deep perineal nerve, superficial perineal nerve, and then some surgeons also performed RPNI of the sural and saphenous nerves. They found that the RPNI group experienced significantly less painful neuromas and phantom limb pain. However, they did find that the operative time in the RPNI group was significantly longer, with 152 minutes versus 90 minutes in the control group. This study was published recently in 2022 and was a retrospective analysis of 28 patients who had insulin-dependent diabetes and underwent either an AKA or a BKA for soft tissue infection. They had 14 patients in their RPNI group and 14 patients in their control group, with a mean follow-up of 49 weeks. They found their RPNI group to experience significantly less pain, as well as significantly less interference based on PROMIS pain interference scores. And they also found that the PROMIS pain interference scores decreased over time versus in the control group, where the interference scores increased over time. And these authors found no significant difference in operative time between the control and RPNI groups. Moving on to RPNI as treatment. The study was published in 2016 and was a retrospective analysis of 17 amputees who underwent RPNI for painful existing neuromas. The majority of their patients had previously undergone a lower extremity amputation, and the etiology for the initial amputation was not reported. These patients had an average of 6 years of neuroma pain prior to this intervention being performed, and their nerve pain was refractory to multiple prior treatments, including desensitization, electrical stimulation therapy, and steroid injections. Of note, they did describe an operative technique where they sought to improve the axon to graft ratio. So for nerves such as the sciatic nerve, they would split the nerve 3 ways and perform 3 RPNIs, and then the common perineal nerve, they split it and performed 2 RPNIs. These authors found that after RPNI of these patients' existing painful neuromas, after a minimum follow-up of 3 months, they saw post-op improvement in neuroma pain scores, phantom limb pain scores, and PROMIS pain interference scores. Moving on to targeted muscle reinnervation as prophylaxis. So again, in the setting of the acute amputation. Of note, the authors in the literature that's about to be discussed all refer back to the next 2 papers that kind of describe the recipe for below and above knee amputations. And again, TMR is where the surgeon is using a major mixed motor and sensory nerve or a pure sensory nerve, and it's coapted to the distal segment of a motor nerve. And pure motor nerves are left untreated as they do not form painful neuromas. So the proposed recipe for BKA TMR is the deep perineal nerve to the tibialis anterior, the superficial perineal nerve to the peroneus longus, and the tibial nerve to the soleus or flexor digitorum longus. And the proposed quote-unquote recipe for above knee amputations is the common perineal nerve to the biceps femoris and the tibial nerve to the semimembranosus. This paper was published in 2018. It was a cohort study where they compared a TMR group at the time of amputation to a control group. The TMR group was studied prospectively, where the control group was studied retrospectively. They evaluated 51 patients who underwent acute TMR and 438 patients who underwent amputation alone. The majority of their patients in both the TMR and the control group had undergone lower extremity amputations. Their indications for amputation were trauma, cancer, infection, and ischemia. Their patients had a minimum follow-up of 3 months, and they found that their TMR group had significantly less residual limb pain and less phantom limb pain based on numerical rating scales and the PROMIS score. And they also found that the prescription of opioids decreased in the oncology group in the TMR group. However, for trauma patients in the TMR group, they saw similar rates of pre and post-op opioid prescriptions. The study was published in 2019 and was a prospective evaluation of 31 patients who were oncology patients and underwent amputation with concurrent TMR. The majority of their patients were lower extremity amputations. In addition to the TMR, they also utilized a multidisciplinary approach where the patients underwent multimodal post-op pain management, an amputee-centered rehabilitation protocol, as well as peer support. They found that their patients who underwent oncologic amputations, in addition to TMR and the multidisciplinary approach, had less frequent and less intense neuroma pain, less phantom limb pain, as well as less residual limb pain. And finally, TMR as a treatment modality for existing pain. The study was published in 2019 and was a prospective randomized control trial of 30 amputee patients who had chronic pain and no prior neuroma treatment. They had 15 patients in their control group where the neuroma was excised and buried in the muscle, and 15 patients in the TMR group. The majority of their patients were lower extremity amputees, with the most common indication for initial amputation being trauma and the second most common being infection. At 1 year postoperatively, their TMR group had a significantly greater change in phantom limb pain based on numerical rating scale, and their TMR group also had favorable but not statistically significant change in residual limb pain rating scale. So in conclusion, some big picture operative considerations. Again, RPNI and TMR can both be performed in both an acute or a delayed fashion. Some contraindications or relative contraindications for these procedures include an open wound or infection, active radiation therapy, and high-dose narcotic use. And it should be noted that RPNI and TMR are not mutually exclusive. While these studies are very specific and evaluate one modality at a time, in reality, they can both be performed at the same time. For example, a common quote-unquote recipe in lower extremity below-knee amputations at this facility is TMR for the perineal and tibial nerves and RPNI for the sural and saphenous nerves. Following up on our cases, ST, the female with dry gangrene of all 4 extremities, underwent bilateral lower extremity TMR and RPNI. She had TMR of the tibial nerve to the medial gastroc muscle, superficial perineal nerve to the peroneus longus muscle, and then RPNI of the sural nerve, saphenous nerve, and deep perineal nerves. She did have some complications with her wound on the left lower extremity requiring revision amputation and systemic antibiotics. However, she is now 10 weeks post-op. Her incisions are well healed and she is not complaining of neuroma or phantom limb pain. LK, our 55-year-old male with the right foot synovial sarcoma, underwent a below-knee amputation without TMR or RPNI. He is now 4 weeks post-op. His incisions are well healed. He does have some phantom limb pain that is being well managed with gabapentin. And finally, SG, our 43-year-old male with the open grade 3 tibia fracture, underwent a below-knee amputation without RPNI or TMR. He is now 3 weeks post-op, and he is denying neuroma or phantom limb pain. So in conclusion, RPNI and TMR have both been shown to be efficacious in regards to prevention and treatment of neuroma pain and phantom limb pain, and have been shown beneficial in both upper and lower extremity amputations performed for trauma, infection, and malignancy. These are my references. Thank you to Dr. Gaston and Dr. Loeffler for their help with this talk.
great presentation, very well organized. Slides are great, very efficient. A couple of questions about the talk. This is a little bit out of my area, as you know, but when we think about both of these procedures, I think what we're really trying to create are satisfied nerve endings so that we don't get into neuromas. Is there anything predictive that would tell you when it's worth the extra effort here? Like, are there some areas where the increased OR time is not really warranted because the risk is low, or are there prognostic factors ahead of time that would lead you one way or the other?
Yeah, I haven't read any specific like indications or recommendations for when to do it versus not, other than obviously with increased OR times, it probably wouldn't be appropriate in the stage of like an unstable patient, or for whatever reason you need to move quickly in the operating room.
One follow-up question. This might be for Brian and his team, but what are the economics of this? Do you obviously it's pretty easy to transect a nerve and let it retract. It's a lot more time consuming and a lot more technically difficult to do a TM and OR procedure. What are the economics? Do you get paid for this or no?
Yeah, so the question is, to answer both is one. Pretty much all the studies that have been done on this have shown that TMR or RPNI is superior to transection of the nerve and letting it retract. And so you put in a little bit of investment at the time of surgery, but you're potentially saving the patients a ton of money in the healthcare system, a ton of money down the road with neuropathic medications, opioids, prosthetic issues with prosthetic fitting, et cetera, and even return to work, and things like that. So it's not a lot of added extra cost, the extra OR time. Obviously, you can get more facile with it, do it more quickly. But I think there's a huge potential savings down the road. We were a little skeptical just taking this on over the last basically 9 years that we've been doing TMR, and kind of widened the patient range that we're doing these for. But even patients that are, diabetic or vasculopaths that you wouldn't think would have a lot of capacity to generate symptomatic neuromas, the studies that have been done have shown improvements in pain, improvements in reducing the risk of neuroma formation, better prosthesis wear, et cetera. So, Glenn and I are on a panel with about a dozen surgeons across the country, a kind of expert TMR RPNI group that just did a consensus statement and paper that's going to be published shortly. And the things that we could all agree on is basically with the body of literature that's out there is, unless you're in a setting where the patient is an acute patient that's unstable, or if you're working in an infected field, or there's some other reason why you got to get them off the table, you pretty much, the ideal thing is to do one of these strategies, TMR or RPNI, at the time of surgery or shortly thereafter. Lou just presented a paper at SOMOS and won best paper of the entire meeting, showing in our study that acute TMR was superior to doing it delayed, so doing it a month later. And the reason is that people set these central pathways and they start neuropathic medications, opioids, and it becomes very difficult to break that chain. If you can address the nerve at the time of the injury and manage it right then and there or shortly thereafter, then you can set them up for success in the future. So there's a great summary of the literature that's out there. Obviously, there's a lot more that needs to be studied. But we're basically in agreement that one of these two strategies really, ideally, is performed for any amputation, really. And some people in the group are a little bit more in favor of TMR, some are more in favor of RPNI. Our strategy is try not to raise large skin flaps to increase the risk of wound complications and things like that. So TMR for large mixed motor sensory, RPNI for the purely sensory. But RPNI seem to work well even on mixed motor sensory as well. The other thing you hit on is, especially with upper extremity and potentially lower extremity in the future, is that when you do TMR, you get that biologic amplification of the nerve signal that can help to drive the myologic prosthetic, give the patient more intuitive control, et cetera.
Yeah, I think to answer your question, there is a code, and it's worth our time to do TMR or RPI. The free muscle graft code that actually isn't terrible. It comes to following the code further down the lines, but it at least is something that's reimbursed for something.
We need to teach our coders that code, because I've been getting that. There's a lot of things we have to teach our coders. That's an enterprise-wide priority right now to get more coders.
Ron, I missed what the benefit is of using a free muscle fat instead of just veering into the existing muscle flat.
So in order for RPNI or TMR to work, you have to denervate the recipient muscle. So if you just take a nerve and vary it in muscle, it's going to form a neuroma at the nerve muscle junction because the axons don't have anywhere to grow into. If you denervate the nerve by cutting the innervation, the branch to the nerve, and then sewing the donor nerve into that, and it can go into all those membrane plates and arborize and not form into a cluster of disorganized nerve. When you do a free muscle graft, you take that small segment of muscle and you obviously completely denervate it there, and it survives the way a skin graft does. You know, basically, from the vascularity that forms around it, it's small enough. If the RPNI muscle graft is too large, then you get central necrosis and it won't work. But that's the difference. And that's actually one of the problems that we're finding is that people, you know, as this is getting spread out and more surgeons are doing it, people are saying, oh, I did RPNI or oh, I did TMR. I took the nerve stuff, did no muscle. And it's like, no wonder it didn't work. You know, you didn't denervate it, you didn't use appropriate size muscle graft, etc.
Yeah, and on that comment, I mean, that's where the basic science study you showed is pretty helpful. And kind of going into Landon's talk to a certain extent, is one of the challenges with the retrospective studies. The RCT done with Kyle Potter and his group is hugely informative because the retrospective data is polluted. Because most of them are control groups from the opioid era. And so we know we're about to hear about opioid-induced hyperalgesia, which really can drive everything. You made a comment in one of your things about multimodal and some of these other things. It's not just multimodal, but it's peer support group. It's being part of a pathway. And so any of these things can be studied and probably have a positive intervention. Yeah. So the RCT is really, really helpful. And then frankly, this is an area where basic science is really helpful to us because it's kind of hard to, I mean, you throw up the slides and it's like, you have this disorganized stuff from dunking in the muscle and you have a total disaster from just doing traction neurectomy. So I think we should be thinking about doing something for each amputation. There are some that where in the setting of you're battling infection at the same time, you're kind of doing interbreedment. Are we going to lose? Are we going to win? Maybe that's not the time, or significant atypical flaps may not be the time. Yeah. But outside of that, if we're doing relatively straightforward amputation, I think at least RPNI is pretty easy for anyone to do. TMR is a little bit, that's a little different level skill set that is beyond my capability.
Right, and that's part of the logistical hurdle for this, is that if I see somebody on a Tuesday, neuropathic or not, it means it's balloony, and I put them on Thursday doing my head here. Logistically speaking, I'm going to do TMR. I need to find an available hand partner to help me do it because nerve transfers are not something I do. And the most critical ones are happening right at vascular structure I'm trying to make not bleed. So it's just not in my skill set, you know. So
I mean, we love to be as available as we can to coordinate. And Joe and I've been doing it for years. But in our study, it was done within 4 weeks. That was so. In a lot of times, what we'll do is we don't even go to the distal end of the residual limb. We go proximal down, make completely separate incision. We're out of the zone of injury where the wound can et cetera. And we can be very targeted about it in terms of just going directly to our recipient motor nerve without doing a massive dissection. And we can transect the nerve more proximally and get the job done. A lot of times we do it outside of the zone as well where their prosthesis is going to fit. So that way you can avoid all the issues of a nerve that's regenerating or a nerve that's irritated from being weight bearing.
Good job. It's